Mary Claire Haver, welcome to the show. How you doing?
Good. Thanks for having me.
I'm so excited to have you. I first became aware of your work. I mean, I know you're a big deal, but I first became aware of your work because I wouldn't call myself as plugged into the menosphere as maybe others maybe, but you made this really powerful reel about your mom who, and obviously it was very sad, and I was personally touched by it because my mom had dementia for many years. Mm-hmm. But you made so many good points in that reel about how we're just not set up for healthy aging today. Right. So I'd love to, I guess, start there. Like, healthy aging. We all want to live longer. We all want to live better. We all want to be free of age-related disease, chronic disability, and yet we're not being set up for that. We're being set up actually for quite the opposite.
Right.
So set us on the right path. How do we age better and live longer?
We have to look at the problem. You know, in my mind, the trajectory for females, when we look at health span and lifespan for females versus males, and again, my whole world is females, right? I'm a gynecologist. I focus on menopause care. So I kind of look at what do we know about women versus men. So women actually win the lifespan game. We win the race. We live 4 to 5 years longer than our male counterparts. So if I had a male twin, I could expect to outlive him by about 4 to 5 years. Sadly, though, 25% of that life would be spent in poorer health than him. Men tend to have a shorter, protracted end-of-life course where they lose independence, right? Where they become frail or, they kind of like have a heart attack and then pass on in general. Women, by and large, tend to have these longer, protracted disease courses. So when my patients come to me, they are mostly focused on getting rid of the menopause fire, right? The things, their brain fog, their hot flashes, whatever is like ruining their day-to-day, their quality of life. So we get that taken care of. Then we set them on a course for staying out of a nursing home, for aging well. And we see a trajectory change in the menopause transition, where the path towards osteoporosis and the path towards dementia tends to hasten for most women. And no one's talking about it. No one's, we understand heart disease, and there's definitely things we can do, nutrition, lifestyle, everything. And so when I really started looking at this and trying to help my patients chart a course so that they can live as healthy as for as long as possible, as healthy as possible, they realized that this is not a normal part of there's no aging program, where they're in the current medical world, the way I was trained and taught, we have a very reactive healthcare system. We don't do a lot of prevention. And so the most fun I have in my clinic is helping them plot out preventative strategies so that they can have a long health span and take advantage of the lifespan they've already been given.
Wow. Well, I just want to double click on something that you said or alluded to earlier. So women tend to have a longer lifespan than men, but they have a shorter health span?
Yeah, the McKinsey report came out a couple of years ago, and they looked at diseases and chronic disease and how much time women are spending in the doctor's office versus men and how much money is spent on their health care. And they realized that women are, by and large, spending 25% of their life in poorer health and plagued with more chronic disease. And when you break that down to like the individual patient, she is really, myself included, focused and motivated on avoiding the diseases that plagued her elders. So
what are we getting wrong?
Well, in the woman side of the world, I was brought up that thin was healthy and thin can be healthy, absolutely. But that was the only thing we focused on, was trying to have a smaller body. And probably in the prime of my life, when I should have been focused on building a bigger body, a stronger body with stronger muscle, more dense bones and bigger muscles, I was focused on cardio and eating as little as possible so that I could stay a certain size. And that was what equated health. And what I realize now is I probably missed my peak bone density and muscle mass in my 30s because I was trying to stay small. So now what I talk to patients about, because I have a body scanner in my office, I'm measuring muscle mass, visceral fat, and I'm having these frank conversations with them about the path that they're on and what can we do from a nutrition standpoint, what can we do from a movement standpoint, what can we do with pharmacology, with supplements, so that we can help you stay healthy and functional longer.
Yeah, you alluded in that reel that was, so profound. It really, it resonated with so many people, and for good reason. You mentioned that your mom, her exercise routine over the years she was essentially just focused on jogging.
Jogging.
Yeah. And and being thin, maintaining thinness as opposed to being strong.
My mother was on a diet for weight loss her entire life. And she was a college athlete. My mom played basketball in college. And I think about that woman who could shoot baskets from 30 feet away and was just always a big boned, kind of muscular person, and seeing her as this, frail, really struggling. Her dementia is terrible. She fell and broke her hip at New Year's. And her recovery from that is just, she is in her 80s, but God, is this my path? Is this what we are? Is this all that's offered to me in my 80s? Because I'm not interested. I don't want that. And I don't want to do that to my kids. And so being in the sandwich generation that I'm in, so I'm 56 and I've got a 24-year-old, a 21-year-old, so I'm still kind of mothering them a little. They're great. They're doing amazing. But, and now I'm like constantly making decisions for my mother. My husband's doing it for his parents at the end of life. And my husband and I look at each other and we're like, okay, what do we need to do? What are we focusing on so that we can stay healthy for as long as possible? Because that wasn't what they focused on. No one ever talked to my mother about how to keep your bones strong, how to not be frail. I mean, she only focused on calories and that scale every day.
Well, there's this it's a very interesting dichotomy, right? Because the primary messaging seems to be around how to prevent heart disease. And you mentioned this, right? Like your mom never developed heart disease. And yet she was told primarily, or at least
eat low fat. We grew up with margarine because it was healthier. Can you imagine?
Same.
My mother would never use butter. We grew up with, even oleo, which is what, and because that was healthy. So low fat, all the trends, she did everything they told her to do. She jogged, which is probably why her heart, she was good at cardio, and, her triglycerides were high. She went on niacin, but it was never really an issue. She never had cholesterol issues or anything. And her dementia is really profound. Her Alzheimer's is awful.
That my mom, the same exact story. My mom was terrified of heart disease the entirety of her life, and ate in a certain way dictated by the messaging she was getting from the agencies, the mainstream media, and the low fat, focus on cardiovascular exercise. Never developed heart disease, but developed crippling dementia at a very young age, 58, Lewy body dementia, and also passed due to cancer. So she never developed heart disease, the one condition that she was
fighting to she was successessful there, but at what cost?
But similarly, I grew up, there was always margarine instead of butter in my fridge, in the yellow Fleischmann's. I mean, I remember it so vividly, and the corn oil by the stove, and never ate eggs. I never saw her, only at the very end of her life, was I able to convince her that eggs were actually a very nutritious food, and she started welcoming
great source of protein.
But no red meat ever. I remember she was taking calcium supplements, and she was doing all these things, and it's just the messaging. We've gotten it so backwards.
I agree. So when I sit down with my patients and we build what I call the menopause toolkit, and it's more of a longevity toolkit for women, and we talk about for them hormone therapy, if they're a good candidate, if it's something they desire, and what do we know it could be preventative for. What is the data showing? Even though the U.S. Preventative Task Force is not caught up yet, and ACOG's, American College of OB-GYN, and the Menopause Society are kind of reluctantly heading in that direction. But we know that estrogen will always protect your bones. Always. We can cut the risk of osteoporotic fracture by 50%. So 1 in 2 women will have an osteoporotic fracture before they die.
1 in 2.
One in 2. And so where we see the biggest morbidity is in the spinal fractures and in the hip fractures. So if you have compressive spinal fractures, women start shrinking as they get older, and it's usually due to their spinal, discs, or not the discs, the bones are compressing from osteoporosis, and it leads to deformity and horrible disability and pain. If a woman breaks her hip after 65 from an osteoporotic fracture, which is the number one cause of this, she has a 29% chance of death in the first year if it's repaired surgically. And if it's not repaired surgically, say she's not healthy enough to survive the surgery and the surgeon makes the decision not to do it, it's a 79% will die in the first year.
Wow.
That is what we're trying to avoid.
So how do we avoid it then? I know you emphasize the value of resistance training, of eating high protein, Creatine?
Enough protein. What is high protein? I have no idea, but enough protein.
Enough protein.
Like now I have my patients emphasize protein and plants. Like those are your top, especially if they're on a GLP-1, like protein and plants are your top priority because we have to keep those muscles strong.
And what are your favorite sources of protein?
I mean, animal-based are the most efficient typically. So lean beef, chicken, pork, turkey. I like a variety because we get different micronutrients and different sources of animal protein. I like a few sources of plant protein to throw in there. I like a mix as long as they get enough amino acids and get a complete protein. I mean, but the flavor palette is the flavor palette, so they have to want to eat it.
Yeah.
It has to feel good and taste good in order for someone to continue to consume it.
Do women tend to undereat protein?
Yes, dramatically. So, and especially meal by meal. So, I trained at University of Texas Medical Branch, and they have an incredible nutrition PhD program there, and they do a lot of work with the elderly. And elderly I'm almost there, by the way. I'm 56,
No.
65. I'm like, it's knocking on my door. Like I would qualify for some of these studies. I'm like, oh my gosh, I'll be 57 very soon. I'm like, we're almost there. And so women tend to have almost no protein with breakfast. So if you eat 3 meals a day, which most women still do, almost no protein with breakfast, a small amount, maybe 10 grams with lunch, just a smidgen with their salad, because again, calories. And then at dinner, they kind of load up on their protein, and that's still maybe 30, 35 grams max. So the average woman is getting, when you include her snacks, probably 60 to 65-ish grams of protein a day. And that is far under eating the amount of protein that we're going to need just to maintain your muscle mass. So when the Women's Health Initiative, study that has been demonized for, interpretation has been demonized for good reason. But there's great data. It's just a data set that came out of there. And one of the things they realized when they looked at frailty scores for women in nursing homes, and they looked at protein intake. The women who ate the highest percentile of protein had the lowest frailty scores when they tried to equalize for everything else. Just eating enough protein will help keep your muscles strong. And keeping your muscles strong will help with your balance, decrease your risk of falls, and that musculoskeletal unit works together. If you have strong muscles, you probably have strong bones.
That makes perfect sense. But sometimes you hear this messaging from the quote-unquote longevity community that high protein diets are somehow antithetical to healthy aging, that eating, lots and lots of protein is going to predispose you to cancer or heart disease or
when we look at,
whatever.
The data that I've seen, when we look at processed meats, a lot of the, sausages and, the way we process meats with a lot of nitrites, so they have a longer shelf life. We're trying to keep food stable. But when that, you add up on your nitrite burden, that is actually the bad actor in like the colon cancer. People who eat a lot of processed meats tend to have a lot more colon cancer than those who don't. It's probably not the meat as much as it is what we do with it. And that's really, there's an innocent kernel of wheat is probably super healthy, right? But it's what we do to it, how we process it, where we're running into problems.
100%. Yeah. It's not even necessary. I mean, I don't even necessarily think that it's processed meat that is as big of a problem as is often that it's often made out to be. I think it's often what we're eating with the processed meat. Like if you're somebody who regularly eats hot dogs, I mean,
right.
I can't remember the last time I had a hot dog. The epidemiology, in my view, it makes perfect sense that it so consistently reflects poorly upon processed meat consumers. Yeah. So eating more protein tends to lead to
stronger muscles and bones and lower risk of frailty with age. And so most, and those numbers kind of tapped out, it was like about 1.6 grams for every kilogram of her, ideal lean body mass is where we started seeing the real benefits, 1.3 to 1.6. So when I'm setting protein goals for my patients, we have an in-body scanner and I got the fancy highest grade one. So I'm looking at her basal metabolic rate. I'm looking at her total muscle mass. I'm looking at our goals for, is she trying to hang on to all that? She's got great muscle mass. We just want to hang on to it. If she's like 110th percentile, 120, she's just a hoss. Are we trying to lose fat? Are we, wanting to gain? So for someone like me, genetically low muscle mass, I am trying to build. And so I'm going higher, for them. So I don't know exactly what high protein exactly is, but I'm just setting goals based on the data we know that's going to keep her out of a nursing home.
Does is menopause really making women gain weight, or is there something else going on?
Oh, thank you for asking such a good question. Yes and no. So it depends on how you define weight gain. So when you look at great study in 2019 that tracked 1,200 women across the transition, meaning from pre-menopause to post-menopause, and you look at the graph just based on the zero axis being menopause, and then plus years and minus years. So we see an acceleration of body fat gain. They didn't look at visceral fat. They just looked at total body fat. The most rapid expansion of body fat gain was in perimenopause when the hormones become irregular. And then it leveled out and you went back on more of an aging track outside of the hormone changes. The inverse happened for muscle mass. We see a dramatic loss much faster than with aging across the menopause transition, and then it kind of leveled out and continued the usual path. So when you put those two together and you just look at BMI was a steady state curve. So some experts will say menopause doesn't cause weight gain. It goes up the same year for year, regardless of her menopause stage, and that is true. But what you're not looking at is body composition changes.
Got it.
So what we're seeing is much more muscle loss, much more fat gain with a steady state weight gain through the transition. It's not inevitable. Definitely there's stuff we can do about it. But if you stay on the prescribed course of what most people do in America, most women do, that is going to be your path.
Well, I love that you said it's not inevitable. Is this shift in body composition due to like the changing hormonal milieu?
Yeah, so
or is it due to the fact
they've broken it down to like the basic biochemistry, but the muscle loss, so testosterone, just like in a man, decreases linearly with age at a slow kind of decline. And we peak at about 30, you guys peak at like 19 or 20. And then you just kind of have this age-related decline.
Sucks.
So yeah, so fortunately you can replace it if you want to, and it can be very helpful. But in menopause, we see, our EKG like ebb and flow month after month in a healthy woman. Then in perimenopause, it is literal, take spaghetti and throw it at the wall chaos. And then in postmenopause, we completely bottom out on estradiol and progesterone, and FSH and LH stay elevated forever until we replace. And so when you look, what's happening on the muscular, we know there are estrogen receptors on the muscle, on the bones, on the ligaments. And so that loss of estrogen is driving more catabolism of the muscle, and we're laying less down. So you're chewing up more muscle than you're building. Unless you change that signal, make sure you're providing enough substrate, and you lift heavy. So the women who are doing that are seeing much more attenuated muscle loss and even gain, through the menopause transition. Most women don't do that. Most women are focused on staying thin. They see the belly fat coming, the scales going up, they immediately calorically restrict, and they start doing more cardio, which is what we've all been taught, right? So they're doing exactly the opposite of what they should be doing to reverse that body composition change.
Well, earlier in the conversation, you said that rather than striving towards thinness, you should have been thinking about getting bigger.
Getting jacked.
Yeah, but that's like
that's hard for a 56-year-old woman to say.
No, I love that you said that, though.
I'm like, I should have been getting jacked. But no, I was trying to be skinny and cute in a bikini, so.
But you can be both. Mm-hmm. Can you not be?
You absolutely can do both. So my daughters are 21 and 24, and I've really tried to instill in them, strong over skinny, nutrition over calories. Like, this is the way. My oldest is in medical school now, and she has an undergrad in nutrition science. So she almost got her RD, but then got accepted to med school first, so she went that path. And my youngest is more PR and marketing and has that more creative brain. But both of them are. I think the younger one is still a little prone to falling into the thin, being cute. But my oldest one is just so body positive and just embraces all shapes and what that really looks like in health. And I think it's because of her nutrition background.
Yeah, nutrition is so crucial, but it's we've got to shift the narrative. And I think things are starting to change. I think, women have embraced resistance training. They're getting there. The problem is no one knows how. And so you'll see me teaming up. Weighted vest is a great hack, and there's decent studies in menopausal and in the elderly women to show improvements in balance and in strength and in osteoporosis measurements. So when they go into their further bone densities, they saw improvements by using a weighted vest.
By using a weighted vest. So when they exercise, so I tell my patients and my followers, you'll see me always on my treadmill. I'll do a lot of filming and all my Zoom calls with my weighted vest on my treadmill while I'm working. And I have a girlfriend group at home in Galveston Galveston, we have a long seawall because we're on the water, and you'll see us all walking with our weighted vest. And now it's become a thing in Galveston where everyone's like, hey, on the seawall with their weighted vest, So it's a really easy hack if you're going to be walking anyway, walking the dog, doing housework. I'm like, throw on a weighted vest. The body responds to all resistance. And this is only going to be helpful. It's not going to be harmful.
Where do you find those? Like Amazon or?
So I got my first one from Amazon, and it works fine. It comes in multiple sizes. You can find some where you can replace. I even had a great conversation with the Go Ruck people, but theirs is more of a backpack situation. And the studies were done with the vest where the weight is more evenly distributed. So I can, confidently say, I can't say the Ruck vest is not going to be helpful, but I feel more confident with the vest situation because that's where the studies were done with vest, not the backpack.
I feel like, the bros.
And they're cuter.
Yeah, that's what I was literally just going to say. That the bros love rucking, but they're not like the weighted vest typically used by Thomas DeLauer and those kinds of guys are not cute. So it's,
and it's a comfort thing. So I'm actually talking to a company about developing one that's more generous to females because women with larger breast and chest are struggling with the vest because they feel tight. And so making one that kind of has an opening to accommodate, things where we're different than the male anatomy.
That makes perfect sense. That doesn't currently exist.
Well, we're working on it.
Wow. Amazing. Talk to me about mental health. For women in general, but over 40. So women over 40, 1 in 4 are on an antidepressant.
Yeah, and it goes, So what we see is SSRI rate doubles across the menopause transition. So we have a 100% increase in the use of antidepressants across the menopause transition. Why is that happening? Okay, 2 reasons. Number 1, we know that when the hormones begin to fluctuate wildly in perimenopause, it directly affects our neurotransmitters. The brain likes uniformity. It doesn't like chaos. So when we go into that chaotic zone and the estradiol levels are fluctuating, we see about a 40% increase in anxiety and depression-related diseases, either worsening of a really well-controlled pre-existing or new onset. And then cognition as well. So like ADHD, brain fog, word salad, all these things. Like 1 in 5 women in the UK quit their jobs. And this is when we're supposed to be leaning in, sharing wisdom, the kids are grown, everybody's out of the house, we're doing our thing now, and they're struggling. I've seen people in really, every job is important, but, doctors, lawyers who are like, I don't think I can safely do my job anymore because I can't remember. And it's purely hormone-related brain fog. So we see the antidepressant use. So doctors didn't know, weren't trained, still aren't trained, and this is a problem in how we educate our clinicians, how to recognize that menopause affects every organ system of our body, especially the brain. And in a perimenopausal patient who has new onset or worsening suddenly with no new stressors in her life, giving her, replacing her hormones or trying to balance her hormones through the transition is going to be more effective than giving her that antidepressant. So I think we could cut back on the use there. The other is SSRIs can help, not nearly as well as hormone therapy, but hormone therapy was demonized for so many years that SSRIs became the most likely drug given to a woman for a hot flash.
SSRIs?
Yes.
That's surprising.
Yeah, it has an indication. So
interesting. I wonder what the mechanism there might be.
Stabilizing the hypothalamus, for whatever reason. So women were given Prozac or, Wellbutrin for hot flashes, and it works okay. So they're taking it. So all of a sudden we see this explosion of SSRI use because of worsening mental health and because of its ability to treat a hot flash when you're not considering hormone therapy as the most logical, reasonable option.
But these drugs are not without their adverse effects. I mean, they're often called side effects, but they're not effects on the side.
Right.
They're effects.
They're effects.
Yeah.
So they're not. I mean, we see, in my world, oh my goodness, one of the biggest things we see is libido. Most of them are libido killers. And so libido is a mood. And so you lose that absolute desire. And hormone loss is doing that anyway. And so we see just women who are absolutely devastated by their loss of the thought process around how enjoyable having an intimate encounter could be. And it's devastating to women.
I can imagine. So would you say that it's reasonable to assert that we have we very likely have an overprescription problem with regards to these antidepressants.
At least this is my world and my expertise. I think it's become instead of, that clinicians are not being trained to consider hormone therapy as the absolutely reasonable and safe option that it could be. And so they're trying to help the patient, and they see this indication for hot flashes and for mental health changes. Okay, here, take this. When the data coming out of Australia right now is very clear that a perimenopausal patient will do better by giving her hormones than she would with an SSRI, and that should be first-line therapy, not in postmenopause, but in perimenopause.
Well, what are the biggest misconceptions around HRT? Like my mom was afraid of it.
And I was too. Okay, I was kind of the 2002 when the Women's Health Initiative, scare tactics were released. I was graduating from my training program and left that institution thinking thou shalt not give hormones, only in the most severe, like she's threatening suicide. There's nothing else you can do. You've tried everything else, including an antidepressant. And I practiced that way for a long time. I mean, to be honest, Max, I was a terrible menopause doctor, but I didn't know it. I thought I was doing everything right. I was a straight A student, blew the top off my boards. I was, I had this. And I just became increasingly frustrated through my years of practice as my patients aged with me, that they were doing worse and worse and worse as they got older. And I'm like, this isn't fit. These are great women. I'm raising kids with them. We're going to church together. We're going to the grocery store. We're hanging out. We're running marathons. And everyone is kind of struggling in one way or the other, mental health, weight gain, whatever, and no one can figure it out. And then when it was my turn and I went through it is when I kind of had that light bulb moment. And I'm so sorry, America, that I waited until my own menopause to realize something's not right. And then I started diving into the literature, meeting other menopause specialists, going to conferences, and realized no one taught me this in my training program. And then in my CME, my continuing medical education, no one was putting this new information in front of me. No one had walked back the WHI and explained how the data really broke out. And I thought, my God, I have to talk about this. I had we all start with no followers on social media. And I'm like, I don't know what's going to happen, but this was not the plan to be have all these millions of followers. But I just felt so compelled to educate as much and as fast and as hard as I could so that women didn't have to suffer. Almost as making up for those years that I was not doing a great job because I didn't know what I didn't know. I don't want to put the blame at the foot of any individual practitioner. We're only as good as what we're taught, right? And if you don't have the time and you're under so much pressure to see so many patients and run to the OR and deliver a baby and do all the things we have to do as OB-GYN, it's going to really be hard for you to catch up with all the new menopause information.
So what does it feel like when a woman goes on HRT for the first time?
Well, I have my experience, and then I can tell you what my patients and other followers are saying. It's like they get their life back. It's not perfect. None of us are perfect. But it is almost as if they get their resilience back. The first thing women complain of is something's not right. I can't put my finger on it, but I'm not the same. And a little bit of this and a little bit of that and a little joint pain and my skin's a little drier and I've gained a little weight and it's a little bit of everything. And, the best thing I could do for a woman would be transplant her 25-year-old ovary back inside of her. But, we don't do that. So menopause hormone therapy is a very slow second place to that. But once they kind of get those hormones back in their body and the neurotransmitters calm down and the hypothalamus calms down and the joint pain and the gut health and everything kind of slowly starts improving, they come into my office in tears that their life has changed, that they feel like they have a new lease on life, that they can handle the life they built. They were managing before, everything was great. They have stress, they have the usual kid, mom, the things we all have. But then the rug got pulled out. So I put the rug back under their feet and now they can manage their lives again. Now, people on social media, who aren't my patients, are telling me that whatever the education we provided, the resources, I have medical articles for them to print out and hand to a doctor. I have scripts of what to say, because I can't be everyone's clinician. And they're like, you gave me the courage to advocate. You gave me the courage to educate myself. And now I found a provider wherever, however, and I'm on track and I have a plan and I feel like I've got this.
Wow. That's amazing. Medical misinformation, it can really take a toll on your mental health and ultimately lead to harm. I was terrified going into my back surgery, and my listeners know I had back surgery recently, and it's a marvel of modern medicine that they were able to go in and replace, my disc, which was, it's restored my quality of life.
Yeah.
And so I'm just imagining like how many women have been
Denied.
This. Yeah.
We're living kind of a half life. And if I give it a correlation, this is going to sound horrible and your male listeners will like absolutely cringe, but it would be as if your testicles shriveled up and died at 51 on average. Some dudes 46, some might make it to 55, but certainly almost every man, 99.9% of men by 57 would have no more testicles.
Damn.
They just be a little sack floating in the breeze.
That doesn't sound fun.
That is exactly what happens to us. So like women are born with all of our eggs and they deteriorate over time until we run out. And that's around the average age of 51. And you guys get a little factory that gets to make their stuff fresh every day.
Yeah. Literally.
And it slows down as you get older, but you're still doing it.
Yeah, it's true. It is true. When is the best time to start?
Good question. I mean, the minute you have symptoms, when we look at mental health, for sure, the earlier the better. The earlier you can stabilize what's going on in the brain, the much better you're going to be for both cognition and mental health. And most likely, especially you have the ApoE4 gene for dementia risk for a woman. If women on hormone therapy with that gene specifically have higher brain volumes and better cognitive scores as they age than women who were not given the opportunity to have that medication. For bones, the earlier the better. For heart disease, we have prevention, we have a window of opportunity. So the estrogen is really protective of the endothelium and the development of plaques and further calcification of plaques and then narrowing and et cetera. And so estrogen just helps keep the elasticity in the endothelium and it decreases the rate of plaque formation. She will probably still develop plaques, but it's going to be later. But once those plaques form, it's not helpful. So estrogen, as far as cardiovascular disease prevention, is better at prevention than cure.
That makes sense.
So telling a woman in her 60s that estrogen could protect her heart is a misnomer.
Got it. So it's better, earlier on. As opposed to later. But is it ever too late?
So it depends on what we're trying to treat. It will always help her bones for her whole life. It will always protect her vagina, and we can do topical vaginal estrogen for that. We're probably going to lose cardiovascular benefit over time, and each woman is different when that happens. But there are cases, and myself included, where I might die with an estradiol patch on, happy as a clam. And as long as I don't develop an absolute contraindication where my life would be in danger from this medication, I will probably continue to use it because at 56, and I don't know how old your demographics are, but I am absolutely living my best life. I wake up happy every day. I am sleeping better. I have better relationships. I have better nutrition. I work out to make myself stronger. I understand my path and where I'm going, and I'm super happy about it. And women are not being allowed to feel that way. They're going and complaining to their clinicians, I don't feel good, I'm gaining weight, I'm not sleeping, and a lot of them are getting patted on the knee and saying, well, this is just what women go through. Wow. At this age.
Yeah, I mean, I see that constantly from my audience is pretty split, but I do have a large, significant female following, and and this is very it's consistent with what I hear. Is a patch, is that a typical administration?
So when we look at human hormones, you have estrogen, I have estrogen, you have testosterone. We all three you have a little bit of everything. You have a lot of testosterone. So we look at how do we replace all three, and would you replace all three? So we usually start with estrogen, and for systemic therapy, meaning I'm going into the bloodstream and we're treating brains, bones, everything, right? You have oral. So two big classes are oral and non-oral. So oral, we ingest, it goes through the stomach, picked up by the liver. When we go to the liver for processing first, that first pass effect of the liver for estrogen, we see a slight uptick in her clotting factors. So for women at risk for clots who've had a history or have a known clotting disorder, we are going to avoid that formulation for her. Oral estradiol is really cheap. And so for a patient on a budget, it could be a really good option. We have lots of strengths. It's easier to kind of titrate. But we do kind of have that, dose-dependent increased risk of clotting for a certain percent. It's very small, but it is there. Then we have non-oral. So, we have patches, pills, creams, gels, rings. Multiple ways to get it into the body, avoiding the gastrointestinal tract. For price, my patients are on a budget. I usually stick with a patch because we have multiple strengths. So have a lot of wiggle room, because in perimenopause, it is literally pinning the tail on a moving donkey. And we have to chase her around to like, get her stable. And then in postmenopause, it's a little bit easier because she's bottomed out. So we're just giving her back, you know. And so the patch has multiple strengths, and it's very, very affordable. For progesterone, the safest formulation does appear to be the body identical progesterone, and oral is best. Doesn't really affect the liver, and we have really good absorption. Progesterone is a huge molecule. It does not absorb well through the skin in its natural form. So we do have progestins through the skin, like what's in a combi patch or some of the commercial preparations, but they're synthetic, and the best safety data does really seem to be in the natural progesterone.
Is testosterone being replaced?
Yes. It's FDA approved for men, as we all know, but there's no FDA approved for women, so you're going to pay out of pocket for it. We want to avoid oral formulations. There's one available in Australia called undecanoate that doesn't affect the liver. It kind of skips the liver, but we don't have it in the U.S. So most of us do injectables or transdermal for testosterone preps. And there's an androgel. So it's a testosterone gel that absorbs really well through the skin, and you know, we monitor their levels. You have to make sure she's absorbing and how much. We don't want to overshoot, but patients are really happy with it. And the nice thing is, because it's formulated for men, that one bottle will last her about 6 months because we don't need very much.
Right.
And with a good RX coupon, we can probably get a bottle for about $60. So I can get my patients' hormones replaced for less than $100 a month with high quality FDA approved body identical hormones.
Wow. Yeah. I mean, women, I feel like...
I know women are paying thousands of dollars. That's why I say that. You don't have to pay that much to get great hormones.
Is it covered? Does HRT tend to be covered by insurance? I have no idea. Yes.
In the forms of estrogen and progestogens, yes.
Just for like wellness?
But sometimes, the way these pharmacy benefits work, sometimes paying out of pocket is cheaper than paying the insurance price. So I'm always like, shop around, ask, see what the prices are, and I can move the prescription from one pharmacy to the other so you can get the best benefit.
Can your lifestyle in your 30s predict how bad your menopause symptoms will be?
So we have things that happen to everyone: loss of muscle, loss of bone, genital urinary syndrome of menopause, that are going to happen, right? And then we have things like hot flashes, night sweats, that, yes, lifestyle can absolutely attenuate that. So kind of how healthy you show up in menopause will sometimes determine your course of, are you going to have really bad hot flashes? So women who are obese tend to have worse hot flashes. Women who have poor nutritional status tend to have worse hot flashes. But I don't want to make anyone feel bad. I have the healthiest people on the planet come to see me who have debilitating symptoms despite perfection in their diet, nutrition, and supplements. And they're still just absolutely, so it's not an all or nothing. It's a trend. But, no one should feel bad because they have bad symptoms.
When it comes to body fat, is there like a specific range?
So, women have more body fat than men naturally, and it's healthy. But when we start moving into, so we've redefined obesity away from just the BMI. So when we're looking at waist hip circumference, so when their abdominal circumference, or I use the waist hip circumference in my clinic, well, we mostly use visceral fat because I really don't care about their curves, When their visceral fat gets above the 100th percentile, we're more likely to be more symptomatic. And there was a great study that I just posted about it yesterday, that looked at visceral fat. The higher your visceral fat, the more likely you are to have osteoporosis.
Wow. And this is basically like the apple-shaped body versus the pear-shaped body,
right? So visceral fat, or belly fat for your listeners, is a very specific type of fat that is intra-abdominal, wrapping around our internal organs. So as a surgeon, it's when I stick a scope in the abdomen and you just see bright yellow everywhere around the omentum. It's wrapping around the bowel, fatty liver. We see it around the stomach, organs. And it's, a real sign that there's some really tough cardiometabolic activity going on.
Yeah, we've talked about quite a bit about visceral fat and how dangerous it can be. On the podcast, we had Dr. Sean Amara, who's he's a physician who focuses on that a lot. But doesn't the hormonal shift that occurs with menopause, doesn't that kind of predispose fat storage in the abdomen, or is that a myth? When
we lose the estrogen, we lose the protection against a lot of forms of inflammation. So you kind of enjoy this like honeymoon period. That's why premenopausal women are healthier than their male counterparts. Probably because we have higher estrogen. And then we pass you guys up and head, off the beaten path. And so we feel like estrogen is really protective. So the loss of estrogen is leading to increased insulin resistance, increasing LDL levels, the ApoB goes up, all with no changes in diet and exercise. So all of that, and then the inflammatory, we see C-reactive protein and sebrates go up. just from being menopausal. So a woman who's in premenopause has a rough, about 8% of her total body fat is visceral or intra-abdominal. And then she crosses over into full menopause and it's up to 23%. So to give you an idea.
Yeah.
So what do we know attenuates that? HRT absolutely attenuates that. Not 100%, but they do see much less accumulation. But high fiber diets, probiotics, a healthier gut, regular movement, zone 2 training, all of that does tend to decrease the amount of visceral fat. Sure, if we starved, that if you lose fat everywhere, you'll lose it there too, but that's not why we're here.
Yeah.
Right? You have to eat to be healthy.
What's your take on these weight loss peptides, these GLP-1 agonist drugs?
So, we do use them judiciously in my clinic, and, women are coming in for basically menopause, right? And a lot of them, especially for the ones who have struggled their whole lives, and I can't fix the obesogenic society we live in. I'm here to help the one patient. I'm praying for the day we get back to where naturally only about 10% of us are obese, but we don't live there yet. We have a lot of changes we have to make. So in the meantime, I really feel like in the right patient selection with the right counseling, these drugs can be miraculous. And what we're seeing they're doing for other addictive behaviors, like alcohol addiction, smoking, gambling, people are out in the one study on alcohol, people are choosing to do those things less with these medications. Something's happening in the brain. What I'm seeing in my patients, we usually start with hormone therapy and we make all the nutrition recommendations and exercise. We bring them back in a few months, redo their body scans and look at visceral fat and their risk moving forward. And then we start the conversation with a GLP-1. That's a whole hour visit where we go through the counseling of how important it is to maintain your muscle mass, what's going to happen when you take this drug, how things slow down moving through the gastrointestinal tract that could cause nausea. I mean, everything has risks and benefits. And we let her make a decision for herself. We take the guilt and the shame out of it and the judgment and let her make a decision. And then we monitor her super close through the process.
A lot of people are now using them to shed a couple pounds for their upcoming holiday.
We
or their
don't
wedding.
do that in our clinic. That is not something I participate in. So this is a medical intervention fraught with its own complications, right? That can be a very important tool. And we are using it to improve their health span. And along with it, heavy counseling around the nutritional changes, the movement changes, all the things they have to build around so that this is going to be sustainable as she gets older. Yeah. Because at the end of the day, so say you just get your GLP-1, you walk out the door, okay? And you end up with 1,000 calorie a day caloric intake because you're just not hungry and you don't want to eat. This happens. You got no counseling. You don't understand protein or how muscle mass, and you go and you lose 25 pounds, okay? If you severely calorically restricted like that, 50%-ish of what you lose is muscle. So the number on the scale is getting lower and you're like, yes, but you have chipped away at 50% of your muscle mass, and it is 10 times harder to put on muscle than it is to put on fat. And so they get off the medication, their basal metabolic rate is much lower because they've lost a chunk of muscle, and all of a sudden they eat the exact same thing they did before, but they're putting on fat because they're not burning as much calorie. I mean, it is the most negative feedback cycle you can get yourself into if you're not careful. So that is what we caution our patients against, is falling into that trap. And what happens to people with low muscle? They have low bone mass. They end up frail and in a nursing home and having fractures. So what I worry about for the people who are not using it judiciously is that we're going to have an epidemic of osteoporosis.
Yeah, I mean, all of the dietary advice that you gave earlier, focusing on prioritizing protein, also resistance training. I mean, it's crucial for everybody across the age spectrum for healthy aging, but it becomes even more important when suddenly you've slashed your daily calorie budget by 1,000 calories thanks to these drugs.
Yeah.
It's do you think that they're unique in the risk to lean mass, or is it that?
No, I mean, when we look at the data around gastric bypass, so the surgical cutting, same thing was happening, but people were just so focused on the number on the scale. But now that we're having increased expansion of the tools we use to measure body composition, and medicine is switching to that measurement, I think we're going to see a lot healthier weight loss than we've seen in the past.
Why do you think some people lose weight on Ozempic but still feel terrible?
Well, the side effects. And so the nausea can be absolutely debilitating. And then also, we talked about compulsive behaviors being reined in. It also seems to put a damper for some patients on their hedonistic center. And so their pleasure center. And some patients come in and they're like, I'm not depressed, but I'm just not happy. They don't want to do anything. They don't want to have sex. They don't want to go anywhere. They're just,
Anhedonic.
Anhedonic, yeah. They've lost the joy. And I'm like, you need to come off. This is not a life you want to be living. And so that is one of the potential side effects of the medication. It's really changing dynamics in marriages. So like as one who takes care of half of a marriage, you see, or half of a relationship, typically, if they're not doing it together, all of a sudden and what did they build their fun time, their relationship on, their friend group, eating and drinking and fun, so fun, right? And all of a sudden one partner doesn't want to do that anymore. Doesn't care, wants to go work out, whatever. And the other partner's like, I don't have a weight problem. Like, let's go to the party. Let's go to the game night. Let's go to whatever. And no, I'm good. And we're just seeing a change in dynamic. So I always counsel my patients about that. Look at how do you celebrate together? How do you relax at the end of a day? You're not going to want to drink. You're not going to want to eat as much. You're not going to, the joy of food might dampen some. And so these are all things to think about.
Yeah, I mean, you got to be mindful of compensating in other ways. I guess food is typically, it's the way we celebrate. It's the way that we express love when we're cooking for our loved ones. I mean, it's something that I really enjoy doing. I have a family member that takes one of these GLP-1 agonists, and maybe I think initially the dose was probably too high, but what he's reported to me is that part of the reason why he is just not hungry over the course of the day is because it makes him feel like crap. Like he's just so nauseous, like the first few days.
So when that gastric emptying is so slow and that food's just sitting in your stomach for longer and moving through the GI tract slower, some patients will feel that way. And that is all what we counsel them about. It looks like with the newer, like with the tirzepatide and semaglutide was kind of the Ozempic, the first big one, and everybody, and that's the GI side effects seem to be worse. We've now switched to starting with tirzepatide in clinic because we're seeing much less of the gastrointestinal side effects.
What is the difference between tirzepatide and
semaglutide? Semaglutide was, there was one before, and there's now liraglutide. Like, everyone is developing a new one, but tirzepatide has two medications in it. It's what's in semaglutide plus the glucagon agonist. So,
interesting.
Yeah, so it's got something extra that kind of takes the edge off. Just doing the semaglutide.
Yeah, I do think that they're revolutionary drugs. I mean, I'm super glad that we have them.
They're fighting the environment that's causing this, but we need to fix the environment.
Yeah, 100%.
It's not a long-term solution.
Yeah.
We're looking at an army. All these kids who we have to fix this. We have to. For the children, they're growing up obese, and they're getting diabetes at earlier ages, and polycystic ovarian syndrome. They're starting their period sooner, and what are we doing?
Got to fix the environment.
Yeah.
Yeah. That is a huge problem. I know you're a fan of creatine.
Yeah.
Creatine for women.
Yeah. Abby Smith Ryan is my goddess of all nutrition research. So she's done a ton on creatine. And so, here's the way Mary Claire approaches the problem. I'm like, okay, osteoporosis, what are we doing? What are we doing for prevention? We know to give her all these meds and they are horrible side effects, whatever, but it will help her bones. But why are we waiting till we get to where she's broken? What do we do for prevention? So that's where I'm reading up on all the exercises and the way to vest. And creatine, turns out, when it combines with resistance training, has an additive effect for muscles. Now, just taking creatine will not grow bone. Okay, I never said that. But when you combine creatine with resistance training, it has an additive effect on bone strength and muscle strength. Amazing. It's very well tolerated. It's very inexpensive. I formulate it myself, and we have it for, in our clinic. And, it's flavorless, tasteless, so easy to mix in anything. And, once you get past the initial little GI part, it causes some bloating when you first start it. You push through that, it's really great. And it just does so many wonderful things. It works at we know it works for muscle and bone, but it works at the level of the mitochondria, making them work better, stronger, faster. So brain health looks really good. We have multiple benefits of creatine. Our creatine stores decline as we age. And so we're just trying to get our stores back up to normal and maintain them.
And also, even if you're not exercising, it's still good for mental health as a supplement. It's still good for brain health. It's still good for mitochondrial function. I mean, because of my back surgery, I haven't been able to work out I'm going on now 2 weeks, and I still take creatine every day.
Don't let your stores drop.
Don't let the store. Yeah. It just seems that its safety record and its efficacy record it goes back.
Is great.
Decades.
And people have devoted their lives to this, and the data is all great. Worst thing they can say is, it didn't help that much. I'm like, I'll take it in anything. People are like, what's your secret? What do you do? I'm like, I do everything. There's not one thing. There's no quick fix in aging and menopause. Like, I literally do everything that reads and is positive. I'm going to talk about recommending it or what it might be helpful for.
Yeah. A question that I often get from my female listeners is like, I'll talk about something like creatine, or I'll talk about like the value, the convenience value of protein powder, for example. And the question that I often get is like, well, what brand do you recommend for women? And it's always such an interesting question to me, because I feel like, where did this come from that women need different
nutritional blocks
products as compared to men?
So
right?
do we need a pink bottle of creatine? Mine is blue. Creatine monohydrate is creatine monohydrate for men, for women, for whatever. So yeah, in a protein supplement, which I use myself because getting in that much protein is hard. So it's just literally a convenience thing for me as well. I mean, there's nothing special about it that makes it for a woman or a man. The package might be prettier, or depending on who makes it.
You pay more for it.
Pay more for it. And so my team is coming up with a protein mixed with creatine. Just kill two birds with one stone product that tastes good and is easy to throw in your berries. And I like to throw in flax and hemp and chia and get all my omegas and, anthocyanins and some probiotics. I'll throw in some yogurt in there. And it's like the biggest bang for my buck for my breakfast in the morning.
Why hasn't anybody thought of that yet? I feel like that makes perfect. It's such a smart idea.
I don't know. I'm sure somebody's doing it. My husband runs the back end of that business. And so he's always on the phone with suppliers and coming up with ideas of, what would be convenient for patients. Women are just kind of coming around, at least in my world, to realizing how beneficial creatine can be. They've got the protein thing down and they're struggling, and I'm like, well, if we're going to do a protein supplement, can we throw some creatine in there and just make it easier for them? My husband's like, let me ask. So we go to the PhDs and make sure that the formulations will gel together and, and be shelf stable and all the things that we need to make it safe. And they're like, absolutely, this is amazing. So that's what we're coming out with.
Makes perfect sense. What dose do you typically recommend for
So at least 5 grams. 3, there are benefits at 3. And especially when she's first starting, I might say give 3 a couple of weeks just to decrease the bloating and some of the water retention. And then once you're past that, 5 a day for females seems to be where the benefits really start kicking in.
Yeah, like I take 5 to 10, but I'm 185 pounds.
Yeah.
Are you a fan of collagen?
Yeah, I am. So again, I was going down the rabbit hole. This is a funnier story. So I was going down the rabbit hole for cellulite. Okay. So I was in the bathroom in a department store. I was in the dressing room, changing, putting on a bathing suit with my daughter in the room. And of course I turn around as like every woman in America, I disparage over my appearance. And I was like, my daughter says, your cellulite's not that ugly, mommy. And I was like, oh God, okay. So then I go home, being the doctor in type A, I was like on PubMed, what can we do for cellulite appearance in women? And it said, there's this study looking at a certain type of collagen, a bioactive collagen called Verisol. And they did a randomized control study on women. They measured the depth of the wrinkles. They looked at wrinkles and cellulite appearance, and they did all these really mathematical calculations on what it looked like. And they saw benefit. And I was like, where do I get this stuff? So then I Google, where do I find Verisol collagen? And I find this company called Sparkle. So I get online and I order it, and it's delicious. It's like lemonade flavor. It tastes great. And can I tell you my cellulite looked amazing? Probably not, but I stopped thinking about it. And I was like, this looks great. But I thought my skin looked great, So it was pure vanity. So I ended up partnering with this company because I talk about it on social and people would buy it. So I ended up partnering with this company and we make our own version of it. And then that same company that developed the Verisol developed a product called Fortibone, and they studied menopausal women with osteopenia and osteoporosis, tracked them for 5 years with bone density scans, and the only intervention they had, they weren't on MHT, hormone therapy, they weren't on any of the bone building medication, and all they did was give them this collagen every day to drink, and they saw improvements in their bone density. And I immediately called my husband and was like, I want this, and let's mix it in with the skin product, and we'll call it Skin and Bone, and that's what we did. And so I'm like, it's not going to hurt anything. Yes, it breaks down to component amino acids. I'll take it. And they saw improvements in bone density. I'm like, if it's helping when you're already losing bone mass at a significant rate, it's probably going to be preventative. So that's the next study I'd like to see.
Collagen breaks down into collagenous peptides. Like it doesn't fully deaminate to
the exact little tiny amino acids.
Yeah.
No, so it's breaking down because you see, you shouldn't be taking collagen, it's ridiculous, whatever. I'm like, listen, it's a source of protein. It's not exactly complete, but it's very close. And it's not going to hurt me. And these women who took it had better bones. I'm in.
Well, I just had back surgery where it involved cutting, into my bones in my back and my spine. And I've been going hard on collagen. I've been taking 20 grams of collagen a day deliberately, along with vitamin C. And my recovery's been, great so far. I've also been prioritizing bone supporting nutrients like boron. I feel like most people are unfamiliar with boron. Really important. Vitamin D, yeah. Magnesium, zinc. What else? Vitamin K2.
Calcium's controversial. One. So there's dietary calcium and then there's calcium supplements, which are two different things. And people don't realize that. So dietary calcium supplements are typically calcium carbonate or calcium citrate or, calcium, usually calcium carbonate. And so when you look at people taking calcium supplements, it does not decrease their risk of an osteoporotic fracture. People who have high dietary calcium from food sources have lower osteoporotic fracture. That's the wrong supplement.
Interesting.
You need a dietary calcium supplement.
So it's just the wrong form?
It's the wrong form.
Wow.
Yeah, that most people are taking.
And also there's this idea.
And it causes kidney stones. And the cardiologists hate it because they feel like it calcifies the plaques faster when you supplement with the traditional supplements. I used to recommend, I was taught to tell people to take Tums or those calcium chews every day. And it does not decrease your risk of osteoporotic fracture. And it's probably giving them kidney stones.
Oh, no.
Yeah.
And cardiovascular events.
Yeah. So I'm like, just make sure you eat lots of food rich in calcium. Though there's a really sweet, I met them. These two young women, mom had early osteoporosis fracture. They read all the data on calcium and they've come up with a dietary calcium supplement that's like made from I think it's dairy-based, calcium. And they've been able to extract it and I tasted it. It tastes delicious.
Well, apparently it's not necessarily that we are walking around deficient of calcium, but rather that the calcium is not being properly directed in our bodies. It's not being shepherded to the parts of our bodies that need it, and instead it's being deposited in soft tissues like our arteries and whatever. And vitamin K2, is apparently very good at, or that's one of its primary roles, is actually directing calcium in the body and keeping it out of places where it's not supposed to be, like soft tissues and things like that. It's all super interesting. So I'm very excited for this book, The New Menopause. Thank you for writing it. I know that this is a topic that we can't be discussing enough, really. Any
discussion of female longevity without this discussion of menopause, I think you're missing half the puzzle.
Did you write it for every woman? Is it written to be something that women should read ideally earlier in life?
The earlier you read it, the better, because you really have to be the CEO of your own healthcare, especially as a female, because we're not teaching our clinicians much clinically significant. I got about an hour of menopause in medical school in 4 years. And then in my OB-GYN residency, I had 6 hours in 4 years. So if you're going to practice menopause care, you have to step out of your regular training. And most clinicians don't have time to do that. I'm not blaming them, right? It's a systemic problem. So it really behooves the patient to educate herself. You can go on my website. I'll give you the article to print out and hand to the doctor and pray, that they're going to be open to receiving new information. And the American College of OB-GYN isn't really pushing menopause care. The Menopause Society is not connected to OB-GYN, but is doing a great job with educational programs for providers and really guidelines to really help do great menopause care.
It's so cool. And you're super active on social media. I know that you've got a massive following and you do a lot of advocacy work and mainstream media. Well, I really appreciate your time. Thanks for coming in.
Thanks for having me.
Yeah, this was so fun. I know that my listeners certainly appreciate the wisdom that you've shared. Just remind people where they can pick up the book, where they can find you on social media. And then I've got one last question for you.
So the book is everywhere you buy books. And we're on social media, Dr. Mary Claire, DrMaryClare. And our website is thepauselife.com.
And I hope your mom is doing well. She's
okay.
Oh man.
No, it's a long slog. She's home from rehab after the hip fracture. She's back in assisted living in her dementia care unit. It's tough.
Man, well, my heart goes out.
She still has good days, so we're clinging on to the good days.
Yeah. Well, you sound like a phenomenal daughter. So
thank you.
Yeah, thank you for doing what you do. The last question that gets asked everybody in the show is, what does living a genius life mean to you?
God, taking control of your own health, really understanding what you're up against, what your genetics is, what your family history, and really taking the time to put yourself first.
Amen. Well, Thanks for coming out.
Thanks for having me.
Yeah, thank you guys. Appreciate you. Share this episode around, and I'll catch you on the next episode. Peace.
Hey, if you liked that video, you need to check out this one here, and I'll see you there.